Here's our presentation on stroke, traumatic brain injury, neurocatastrophes, and all things bad that go on in the head. We'll talk about ischemic stroke, hemorrhagic strokes, intracranial bleeds, traumatic brain injury. We're talking about assessment and management and establishing a differential diagnosis and a working field diagnosis of what's going on. CVO always takes precedence. Sometimes we'll need to step in and do some things immediately. In some cases, a traumatic brain injury or a severe neurocatastrophe may render the patient to be hypoventilating. We need to step in for that. And these patients are also prone to seizures. So fairly complex chart here, which we provide separately for you in its own format. Some of these guys are in neurogenic shock along with it, hypovolemic shock along with it. And this is really the multi-systems trauma patient. More than what we're considering with a stroke or a somewhat medical cause. And the bottom line is we want to keep everything normal, which we'll emphasize here. Do your good field neuro exam. Do that stroke scale, whichever one you're going to use. Be aware that some of the stroke scales don't catch very much on the posterior strokes, large vessel occlusion strokes. Check those pupils. Know your GCS. Have a reference card. Be able to quickly and accurately determine the GCS of these patients. Guessing doesn't cut it. You're paramedics. If you don't know it, then you've got to have a reference card so you can get it right. Mrs. Smith isn't as worried about your memory as she is your accuracy, so use your reference cards. So field neuro exam, stroke scale, pupils, Glasgow, and then the cranial nerves. Can they hear? Can they see? Can they smell? Can they taste? Can they move their head and face around? Yeah, I agree that the smell and the taste is probably not something we can always do in the field. And, if you can do it, that's great. But you can have them smile. You can have them shrug their shoulders. You can see if they can move around while you're looking for slurred speech and facial droop and all those kinds of things. Any chance your patient's postictal? Is there a chance that this is showing up as a seizure and you didn't see the seizure, it wasn't reported to you? So maybe it is a neurocatastrophe. Sometimes those first-time seizures are really a critical neuro event that's just popping up. Also realize that Bell's palsy can look very much like a stroke. Actually, I think it looks more dramatic than a stroke, but not be a stroke. Those patients are going to have the facial changes, but they're not going to have the one-sided weakness. So let's don't get fooled by that. We were smarter than that. Check glucose. Hypoglycemia can look like a stroke. Check for temp, hypo or hyperthermia. Maybe alcohol's involved. Maybe drugs are involved. Maybe there's meds involved that were either intentionally or accidentally overdone or over-medicated or overdosed. So there's lots of possible causes of altered mental status. There's lots of possible causes of seizures. There's lots of possible causes that could put us in this thing where we have this patient that we're really not sure if it's a critical neuro event or not. But if you're in doubt, stroke alert these people. Let's get resources moving and do that quickly as soon as you know it. Don't save that for your phone or radio report when you're 5 minutes out. As soon as you think it's a stroke, say something. You don't have to give your full report then. You don't have to have completed all of your evaluation. You just have to have put that as at the top of your differential list for now. Give them an alert and get those resources moving. Then you can get on the road and deal with IVs and 12 leads and all those things that everybody wants that can be all ready by the time you get there. And if you don't get them done, you don't get them done. Time is brain cells. And so you need to get moving when you think that there's something critical neuro going on. Let's check for elevated intracranial pressure. Let's look for those 3 signs. Let's look for strange breathing patterns or not breathing adequately. Let's look for elevated blood pressure and then the reflex bradycardia that goes along with that. The blood pressure is a good thing. Hypertension is a good thing. If there's elevated intracranial pressure, the patient's mean arterial pressure has raised in order to continue forcing blood into their skull. That's a good thing. If you drop that pressure, then you can hypoperfuse their brain. Don't be messing with their blood pressure. And why are they bradycardic? Well, because they're hypertensive. It's a reflex. So know those three things. Assess for shock. If they're in shock, deal with that. These patients don't do well if they get hypotensive. They don't do well if they get hypoxic. Don't let that happen. Keep everything normal except for the BP. Keep their glucose normal, their pulse ox normal, their capnography normal. Keep everything normal and within normal ranges, but don't mess with that BP. If you're going to think about lowering blood pressure, you should call and talk to a doc and have them make you do it over the phone, and you should still probably be a little concerned about that. What if your patient has a seizure during transport? Well, be sure that you're ready. If you know, take your narcs into the scene. That would be pretty aggressive, pretty proactive. But certainly once you've arrived at neuro is the problem, then why wouldn't they seize? Expect them to seize. Get your narcs out, be ready. I'm not saying draw it up. I'm saying have them where you can get them and have them administered within 60 seconds of the seizure starting. Do your history and physical. Let's look for head trauma. Let's look for oral trauma, urinary incontinence. Do that full field neuro exam. Get all the vitals. Full set of vitals means a lot more than blood pressure, heart rate, and breathing rate in a pulse ox. So get the whole shooting match on these people. Get your partner to help you. Get all the data you can. Verify that it's valid data. Get all the data you can. 3 quick takeaways. These are emergency cases. Get moving. There's a reason why there's a stroke alert and a stroke team. Critical neuro things are an emergent situation. Let's go. Get done what you can get done on the way. Let's make sure you've ruled out other stuff, though. Don't be bringing somebody in stroke alert who has a blood sugar of 40. Let's make sure you've ruled out obvious stuff. But let's kind of increase our speed a little bit and a little zip and get moving. And then try to keep everything normal. Leave that BP alone, but try to keep everything else normalized. We don't want them hyperglycemic anymore. We want them hypoglycemic. We want them normal capnic. We want them with a normal pulse ox reading, normal for them, and work on it that way while you move quickly and efficiently to the hospital. So that's neuro stuff.